my name is Chris Lee. I'm a respirologist and sleep specialist at St. Michael's Hospital. For this online learning experience, we're going to be talking about obstructive sleep apnea. There are two parts to this series. The first part is focused on pathophysiology and diagnosis. I have no relevant disclosures for this presentation. This lecture will be meeting the following end-of-week learning objectives. 1. Describe the pathophysiology, clinical manifestations, and management of obstructive sleep apnea. 2. Explain the role of polysomnography in making a diagnosis of obstructive sleep apnea and investigating for other sleep-related breathing disorders. 3. Describe how obstructive sleep apnea adversely affects the body, including worsening of hypertension and increased risk for cardiovascular disease. 4. Explain management of obstructive sleep apnea, including CPAP, weight loss, and alternative remedies such as positional therapy and dental appliances. For this first part of the module, we will be focusing on the first of those two objectives, the pathophysiology and clinical manifestations of obstructive sleep apnea, and explaining the role of polysomnography in making a diagnosis. This is what we're going to be talking about over the next little while. We're going to start with a case presentation, move into a little bit of information on causes of sleepiness. We'll talk about what sleep apnea is and the pathophysiology of it. Then we'll talk a little bit about clinical manifestations and go into some prediction rules and making the diagnosis of sleep apnea. Let's talk about a case first. Jason, a 48-year-old man, comes to your office with the following concerns. He has daytime sleepiness. He's dozing off at work. He has loud, disruptive snoring and witnessed choking and gasping spells. He has unrefreshing sleep. Otherwise, he's healthy, except for a history of hypertension. His only medication is hydrochlorothiazide, taken for the hypertension. You examine Jason in your office and notice that he looks tired. He has a body mass index of 34 and a neck circumference of 45 centimeters. When you look into his oropharynx, you find that it looks very crowded. The remainder of his exam, however, is normal. Let's talk a little bit about what sorts of things can cause daytime sleepiness. This is a very common presentation to a doctor's office, and so it's worth knowing a little bit about the differential diagnosis for daytime sleepiness. I like to think about sleepiness in terms of 4 major categories. The first category is just not getting enough sleep. The second category, for lack of a better term, is lousy sleep, or things that are causing sleep disruption. The third category is people who are just plain sleepy. And the fourth category is mood and medications. So under category 1, not enough sleep, there would be sleep restriction, which just means not getting enough hours of sleep. Insomnia, so people who have difficulty falling asleep or staying asleep. And circadian problems, so people who have a body clock that's misaligned with the rest of the world. Under lousy sleep, that would include what we sometimes think of being intrinsic problems with a person's sleep. So sleep disordered breathing, sleep apnea, repetitive limb movements during sleep. And under the just plain sleepy category, there's primary CNS disorders of sleepiness like narcolepsy and idiopathic hypersomnolence. And finally, under mood and medications, there's depression and other general medical conditions and their treatments, which often can lead to some sleepiness as well. What is obstructive sleep apnea? Sleep apnea is a common disorder. It is characterized by recurrent episodes of pharyngeal collapse. So that airway is just collapsing on itself, and this leads to a few things. First of all, there can be a complete cessation in breathing, also known as an apnea. But sometimes the collapse of the pharynx is incomplete, and what we see instead in those cases is a discernible reduction in breathing associated with some other event of physiologic significance, such as a desaturation or an arousal. This type of event is sometimes termed a hypopnea. And both of these events, breathing events, can be associated with consequences in terms of the sleep, so sleep disruption. Obstructive sleep apnea is defined by something called the Apnea-Hypopnea Index, or AHI. And we measure the AHI by doing something called a polysomnogram, or a sleep study. What is the AHI? Well, it is the total number of apneas and hypopneas experienced by the patient during the night, divided by the total amount of time that the patient slept for during the test. A normal person can have some apneas and hypopneas during the night. And in fact, a normal person can have up to about 5 of these events per hour. So anything less than 5 in terms of the apnea-hypopnea index is considered to be normal. Mild obstructive sleep apnea is considered to be an AHI between 5 and 15 events per hour. Moderate OSA would be 15 to 30 events per hour. And when you get above 30 events per hour, we call this severe OSA. In terms of the prevalence of OSA, it is actually a startlingly common condition. We have data from a cohort of patients studied in Wisconsin in the United States in the 1980s. These patients were actually government workers who were screened for obstructive sleep apnea with a sleep study. And what they found in Wisconsin was that men had a prevalence of obstructive sleep apnea of 24%, and women 9%, if one uses an AHI cutoff of 5. Using an AHI cutoff of 15, which is the starting point of moderate sleep apnea, the prevalence did go down a bit to 9% in men and 4% in women. Now, if you go back and look at an AHI cutoff of 5, but also consider whether the patient had symptoms of daytime sleepiness, then the numbers are a bit smaller. So 4% in men and 2% in women. So what does this tell you? Well, this tells you that the abnormality of sleep apnea, stops in breathing during sleep, on a polysomnogram is very, very common. But people do not always have symptoms related to the sleep apnea. And so what we sometimes refer to as sleep apnea syndrome, or OSAS, is a bit less common, but still very common in the general population. The pathophysiology of sleep apnea we discussed in our large group lecture. But essentially, just to summarize that, it comes down to a balance of forces. So if we think of the upper airway as a tubular structure, and we look at it in cross-section, the patency of this tubular structure is dependent on the balance of forces. There are inward forces, which would tend to cause airway collapse, and there are outward forces, which tend to promote airway patency. During wakefulness, these forces are well balanced. But when a person goes to sleep, things change. In sleep, there is reduced upper airway dilator muscle activity. And this leads to more of a propensity for the airway to collapse. This propensity to airway collapse in sleep leads to the stops in breathing, or apnea, or the partial airway collapse that is characterized by hypopnea. There are a number of anatomical risk factors that can increase the risk of that airway collapsing. The first of these would be excess airway soft tissue, which is often the case in people with obesity. The second would be nasal obstruction, and the third would be adenotonsillar hypertrophy. A short mandible can often also increase the risk of having obstructive sleep apnea. In terms of clinical manifestations, we know that obstructive sleep apnea can cause significant sleep disruption, and this leads to both nighttime and daytime symptoms. When we think about the nighttime symptoms of sleep apnea, one of the things that commonly brings patients to our attention is the snoring. And the snoring is not generally noted by the patient themselves. It's noted by typically a spouse or a family member or somebody else that is there to hear the snoring. Patients are sometimes aware of choking and gasping sensations and may actually wake up with these feelings. Others sometimes witness the patient going apneic during the night. The patient often feels that their sleep is very restless and that they wake up a lot during the night. Sometimes patients will report that they end up going to the bathroom a lot during the night because of nocturia. The daytime symptoms of sleep apnea are unrefreshing sleep, morning headaches are fairly common, and daytime sleepiness is a common complaint in patients with sleep apnea. Often people are dozing off in situations that are inappropriate, including sometimes during active situations such as even driving a car. Patients will also sometimes report that they have some neurocognitive symptoms such as poor concentration or memory impairment. They might have some mood symptoms such as depressed mood or irritability. In terms of deciding which patients should have a test for obstructive sleep apnea, we have a number of prediction rules that can help us with this. As you can imagine, the symptoms of sleep apnea are quite non-specific and quite common, and so it would be helpful to have a prediction rule that allowed us to sort of prioritize who should have a test for this condition. There are actually many prediction rules for determining the likelihood of a patient having obstructive sleep apnea. Most of them involve some sort of combination of anthropomorphic data, so measurements, and historical items, such as snoring. Unfortunately, no predictive rule has adequate sensitivity and specificity for us to say you don't even need a test. But the prediction rules can help us decide how to prioritize people for testing. One of the prediction rules that I like to use is called the adjusted neck circumference. The adjusted neck circumference takes the patient's measured neck circumference and then adjusts it for certain other historical factors. So for example, if the patient has a history of hypertension, we would add 4 centimeters to the measurement. If there is habitual snoring, we would add 3 centimeters to the measurement. And if the patient is reported to have choking or gasping episodes on most nights, we would add another 3 centimeters to the measurement. Adding all of these factors together gives us something called the adjusted neck circumference, which then is used to stratify risk of sleep apnea. So if the adjusted neck circumference is less than 43 centimeters, there is a low clinical probability of having obstructive sleep apnea. A circumference of 43 to 48 centimeters confers an intermediate risk, and a neck circumference over 48 centimeters is a high-risk patient. Let's go back and think about our patient Jason. Jason had a neck circumference of 45 centimeters. He also had a history of hypertension. He was definitely known to be a snorer, and was also noted to have some choking and gasping spells during sleep. So adding it all up, he has an adjusted neck circumference of 55 centimeters of water, which would put him in a very high probability category of having obstructive sleep apnea. There are some other prediction rules that are used, one of which was developed here in Toronto. The Stop-Bang questionnaire was developed in the preoperative setting for assessing the risk of finding a pre-op patient with obstructive sleep apnea. It has since been validated in a number of other settings. The Berlin questionnaire is another commonly used prediction rule, which does not involve any measurements, but simply takes historical factors to determine the risk of sleep apnea. Now, how do we actually make a diagnosis of sleep apnea? Well, the gold standard for making a diagnosis is to do something called a polysomnogram, or PSG. This is an overnight sleep test, usually conducted in a sleep lab with a technologist who is in attendance during the night. We monitor a number of different things on a polysomnogram, including EEG monitoring, so that we can determine when the patient is awake and when they are asleep, and which stage of sleep they are in. We also monitor respiratory channels, typically a flow sensor at the nose and or the mouth, to determine airflow. This allows us to determine when the patient is having apneas. We also have some bands that go around the chest and the abdomen, and these help us decide whether the event that is occurring, an apnea for example, is obstructive or central. The other respiratory monitoring that we use is an oxygen saturation probe, which is usually fixed to the patient's finger. There is some simple single-lead ECG monitoring during the test, and also some EMG channels, including the legs and the chin. Also recorded during the night is the patient's body position. This is an example of what a polysomnogram looks like. So at the very top, we have 2 leads of EEG, followed by some electrooculogram leads, and below that, chin EMG. The red tracing is the electrocardiogram, and below that are some leg leads. There's a red line that is going up and down, and that is the oxygen saturation, and then a blue line below that for flow, or nasal flow. The chest and the abdomen leads are below that, and at the very bottom is the snoring channel. The things to note here are that there are some periods of apnea where there is no flow, lasting at least 10 seconds. That's part of the definition of an apnea. We also have some cyclic desaturations in that red oxygen saturation tracing. And there is some snoring in the bottom channel there, the microphone that is picking up the noise. So this is consistent with an obstructive apnea. You will notice that there is some ongoing movement in the chest and the abdomen leads in the absence of any airflow, which is how this event in particular is characterized as an obstructive event, because there's ongoing effort despite an absence of airflow. This is what Jason's polysomnogram looked like. When you get a polysomnogram report, this will show up on most report formats. There is usually a graphical summary page that looks something like this. This gives you sort of a snapshot of what happened during the night at a glance. On the top box is something called the hypnogram, which tells us when the patient was awake and when they were asleep. You will note that the green bar on the hypnogram denotes REM sleep. The box below that is for respiratory events. And this is subdivided into apneas, both obstructive and central, and hypopneas. The box below that is for oxygen saturation, and then below for body position, and finally at the bottom is the snoring or sound channel. The important features here are that there are very frequent obstructive events. Some of these are obstructive apneas, although the majority of them appear to be hypopneas. And there is significant oxygen desaturation during the study as well. In terms of the actual numbers, the apnea-hypopnea index for Jason turned out to be well into the severe category at 79.2 events per hour. And the lowest oxygen saturation during the test was quite low at 74%. It is recognized that coming in to do an overnight sleep test is not perhaps the most convenient thing to do, and the laboratory environment is not always the most conducive environment to actually sleeping. Because of this, there has been a lot of interest in home sleep testing devices to try and improve the convenience for patients, to reduce the labor intensiveness of attended sleep studies, and perhaps allow us to monitor patients in their home setting. What the home sleep testing devices do is allow for unattended studies in the home with a limited set of monitoring equipment. These sleep studies are typically geared primarily for the diagnosis of sleep apnea in patients who don't have a lot of comorbidities and are otherwise relatively uncomplicated. And in certain jurisdictions, this is the primary method of diagnosing obstructive sleep apnea. Whether home sleep testing is used often depends largely on the relative ease of access to the in-lab polysomnogram test. To summarize our key messages from part 1 of the obstructive sleep apnea module, number 1, obstructive sleep apnea is a common disorder characterized by recurrent pharyngeal collapse leading to apneas and hypopneas. Number 2, patients with OSA present with snoring, choking and gasping spells, sleep disruption, unrefreshing sleep, daytime sleepiness, mood disturbance, and neurocognitive symptoms. Prediction rules can be used to help decide which patients should undergo sleep testing. And finally, the gold standard for diagnosis of sleep apnea is polysomnography. On a polysomnogram test, an apnea-hypopnea index greater than 5 events per hour is considered to be abnormal. So by now, you should be able to describe the pathophysiology and clinical manifestations of obstructive sleep apnea, and explain the role of polysomnography in making a diagnosis of obstructive sleep apnea and in investigating for other sleep-related breathing disorders. That's all for now. Thank you for your attention. We'll see you again in part 2.